Welcome to the deep dive. Today, we're tackling, well, a really critical topic. The adrenal glands, these two tiny glands, sitting right on top of your kidneys. They're basically running the show when it comes to homeostasis.
Absolutely. They control how you handle stress, manage blood pressure, regulate huge parts of your metabolism, all through hormones like cortisol and aldosterone.
Yeah, and we've been diving deep into sources covering the whole spectrum of what happens when things go wrong. We're talking about adrenal disorders, conditions where the body makes either way too much or, crucially, way too little of these essential hormones.
And it's not simple. These conditions can cause profound hormonal starvation or, on the flip side, a sort of chronic, damaging overload.
The symptoms could be tricky too, right? Often vague, looking like other common problems. But the underlying issue is serious, sometimes even life-threatening.
Exactly. So our mission here is to give you a clear roadmap. Adrenal conditions. They can confuse even experienced doctors because the symptoms are, well, all over the place. So we're focusing on the key clinical signs, those specific electrolyte patterns. They really are like a physiological fingerprint, and the diagnostic strategies that help tell these conditions apart. Our goal is to get you well-informed, fast.
So the scope today covers both sides of the coin. We'll look at the failure states, primary adrenal insufficiency, that's Addison's disease, and secondary adrenal insufficiency. And we can't forget the emergency situation, adrenal crisis.
Right.
Then we'll switch gears to the excess states, Cushing syndrome, which is too much cortisol, and primary hyperaldosteronism, also known as Conn syndrome, dealing with too much aldosterone.
And the core lesson, really, the big takeaway we're aiming for today is this. If you understand the adrenals, you understand how the body fundamentally manages salt, sugar, and stress. It's all interconnected.
Okay.
So let's start by unpacking what happens when the system fails, when the adrenals just aren't working properly. Let's look at adrenal insufficiency.
All right, let's dive into primary adrenal insufficiency, PAI. Most people probably know it as Addison's disease. The key word here is primary, meaning the problem is right there in the adrenal cortex itself.
Exactly. It's a chronic failure. It progresses over time, and it leads to a major deficiency of both key steroid hormones: cortisol, the glucocorticoid, and aldosterone, the mineralocorticoid.
What's usually causing this destruction?
Well, historically, infections like TB were a big player. But today, especially in developed countries, the sources are really clear. It's almost always autoimmune destruction, autoimmune adrenalitis. The body basically turns on itself, creating antibodies that attack the adrenal cortex cells.
Wow. And it takes a lot of damage before you even see symptoms, right?
Oh, yeah. It's insidious. You need to lose something like over 90% of the adrenal cortex function before the clinical signs really become obvious.
Okay, so you've lost both cortisol and aldosterone. This creates a kind of triad of deficiencies, doesn't it? That paints the classic picture.
Precisely. Let's break that down. First, you've got the cortisol deficiency. Cortisol is absolutely vital for maintaining blood pressure, keeping blood vessels responsive to things like norepinephrine. Without it, you lose that vascular tone.
Leading to low blood pressure.
Exactly. Low blood pressure, profound fatigue, just generalized weakness. Cortisol also helps regulate appetite and blood sugar. So low cortisol means weight loss, no appetite anorexia, and a real risk of hypoglycemia, low blood sugar. People often miss that, but it's a major flag, especially in an acute crisis.
But the thing that really sets primary AI apart, the key differentiator from other types of adrenal failure, is losing aldosterone at the same time.
That's the crucial piece of the puzzle, diagnostically speaking. Aldosterone's main job is to conserve salt. It tells the kidneys, specifically the distal tubules, to hang on to sodium and get rid of potassium and hydrogen ions in exchange.
So when aldosterone fails,
You get massive sodium loss through the kidneys. This leads straight to volume depletion, severe dehydration, and that feeds back into the severe hypotension, dizziness, even fainting or syncope. And because you're dumping sodium and holding on to potassium, you see that absolute hallmark lab pattern: hyponatremia, low sodium, and hyperkalemia, high potassium.
and that intense salt craving people talk about with Addison's, that's the body just screaming for sodium.
It absolutely is. The body is desperately trying to replace what it's losing. And it's a bit of a vicious cycle, too. The volume depletion also triggers ADH, antidiuretic hormone release.
Right, which makes you hold on to water.
Exactly. Which then dilutes the remaining sodium even further, worsening the hyponatremia. So the low sodium is partly true salt loss and partly dilution.
Okay, that covers cortisol and aldosterone loss. What's the third piece, the visual clue?
Ah, yes, that's the ACTH elevation. See, the adrenal cortex isn't making cortisol, so the pituitary gland doesn't get its negative feedback signal. It thinks, hey, we need more cortisol, and starts pumping out huge amounts of ACTH, adrenocorticotropic hormone, trying to stimulate the failing adrenals.
And ACTH is linked to skin pigment.
It is, indirectly. ACTH is made from a larger precursor molecule called POMC, propaeomelanocortin, and that same precursor molecule also gets cleaved to produce melanocyte-stimulating hormone, or MSH.
So high ACTH means high MSH.
Bingo. And high MSH stimulates melanocytes, causing that classic hyperpigmentation. You see it often in sun-exposed areas, but very characteristically in places like friction points, elbows, knuckles, and especially in the creases of the palms and inside the mouth on the buccal mucosa.
So putting it all together for someone trying to spot this.
The combination is pretty unmistakable if you know what to look for. Hyperpigmentation plus hyperkalemia plus hyponatremia plus hypotension and maybe that salt craving. That specific electrolyte pattern, low sodium, high potassium, is the direct result of losing both cortisol and aldosterone at the source, the adrenal gland itself.
And it's worth remembering, isn't it, that autoimmune Addison's often doesn't travel alone. The sources mentioned, it frequently clusters with other autoimmune conditions.
That's a really important clinical pearl. If you see someone with, say, type 1 diabetes or Hashimoto's thyroiditis or maybe new onset vitiligo, and then they start complaining of this crushing fatigue, weight loss, Addison's has got to be high on your differential diagnosis list. You need that holistic view.
Okay, so how do we confirm it? Diagnosis.
Well, the initial labs will often show low morning cortisol, which makes sense, and crucially, that high ACTH level. That tells you the pituitary is trying, but the adrenal isn't responding. You'll also see the hyponatremia and hyperkalemia.
But the gold standard test
is the cosintropin stimulation test. Cosintropin is just synthetic ACTH. We give a dose, usually IV, and watch the cortisol response.
which should happen normally.
A healthy adrenal gland should respond vigorously, pumping out a lot more cortisol, usually reaching a level above 18 or 20 micrograms per deciliter after 30 or 60 minutes.
And in primary AI.
If the adrenal cortex is destroyed, like by autoimmunity and Addison's, it simply can't respond no matter how much ACTH you give it. So an inadequate cortisol rise after giving cosintropin confirms that the problem is indeed primary adrenal failure.
Makes sense. And since the problem is the lack of both hormones, the treatment has to replace both too.
Absolutely non-negotiable. These patients need glucocorticoid replacement, usually hydrocortisone, sometimes prednisone, and critically, they also need mineralocorticoid replacement, which is fludrocortisone.
Why is the fludrocortisone so important? Doesn't hydrocortisone have some mineralocorticoid effect?
It has a little, yes, but it's almost never enough. The sources really emphasize this. To fix the salt wasting, the hyperkalemia, the orthostatic hypotension caused by the aldosterone deficiency, you need fludrocortisone. It's essential for restoring that sodium-potassium balance and stabilizing their blood volume and pressure. Hydrocortisone alone just won't cut it. Hashtag tag 1.2. The alternative failure, secondary adrenal insufficiency, SAI.
Okay, so primary AI is failure at the adrenal gland. Now let's shift focus centrally to the pituitary. This is secondary adrenal insufficiency, or SAI.
Right. Here, the adrenals themselves might be fine, but the pituitary gland, the conductor, if you will, isn't sending out enough ACTH. So you still get cortisol deficiency, but the underlying cause and the resulting picture are really quite different.
And the key difference comes down to aldosterone again, doesn't it?
It absolutely does. This is the central point. Aldosterone production is preserved in SAI. It remains normal.
Why is that?
Because aldosterone secretion isn't primarily controlled by ACTH, it's mainly regulated by the renin-angiotensin system, the RAS, which responds to blood volume and potassium levels. Since that system is intact and the aldosterone-producing part of the adrenal cortex doesn't rely on ACTH, it keeps working just fine.
What causes SAI? I know the most common reason is actually stopping long-term steroid medication, right? That suppresses the whole axis.
That's correct. Iatrogenic suppression from chronic exogenous steroid use is definitely the most frequent cause we see. But classic textbook examples exist too, like Sheehan syndrome.
Oh, yes, Sheehan's. That's related to childbirth.
Exactly. It's basically pituitary damage, specifically ischemic necrosis, caused by severe blood loss and low blood pressure during or after childbirth. The pituitary is vulnerable to ischemia then, and the lack of blood flow can kill off hormone-producing cells, including the ones making ACTH.
And often other pituitary hormones are lost too.
Yes, that's common in Sheehan's. You might see deficiencies in hormones controlling thyroid function, gonadotropins, prolactin.
So comparing SAI to PAI, the clinical fingerprints are going to be quite distinct. because of that preserved aldosterone and the low ACTH.
Strikingly different. Let's tick through them. First, pigmentation. In SAI, ACTH levels are low. Therefore, no excessive MSH co-secretion. Result? No hyperpigmentation. That classic bronze skin of Addison's is absent.
Okay, no tan. What about the electrolytes?
This is the absolute key differentiator. Because aldosterone is working fine, the kidneys handle potassium normally. Result? Normal potassium. Hyperkalemia does not occur in isolated SAI.
Huge difference from PAI, but they can still have low sodium hyponatremia.
Yes, they often do. But the mechanism is different. In SAI, the hyponatremia is primarily elutional. It's not to be related to inappropriate ADH secretion or impaired water excretion due to the cortisol deficiency itself, rather than massive salt loss like in PAI. So they're tired, hypotensive from low cortisol, and might have low sodium, but their potassium is normal.
And if it's something like Sheehan's, you might see other clues pointing to the pituitary.
Yeah, definitely. The loss of other pituitary hormones gives you associated symptoms. Prolactin deficiency means failure to lactate postpartum. Loss of FSHLH can cause loss of pubic and axillary hair or menstrual problems. These additional signs really point towards a central pituitary origin.
So the lab pattern sums it up. Low ACTH, low cortisol, often hyponatremia, but crucially, normal potassium. That pattern effectively rules out PAI and points straight to the pituitary or hypothalamus.
Correct. And because aldosterone is okay, the management strategy changes too.
Right, no need for fludrocortisone here.
Exactly. Management requires only glucocorticoid replacement, hydrocortisone, or prednisone. Since the body's renin-angiotensin-aldosterone system is handling salt and potassium balance correctly, mineralocorticoid replacement isn't needed.
But there's a really important warning about starting treatment if other pituitary hormones are also low, particularly thyroid hormone.
Yes, this is a life-saving point. If a patient has both secondary adrenal insufficiency, low ACTH, and secondary hypothyroidism, low TSH from pituitary failure, you must start the glucocorticoid replacement first.
Why is the order so critical?
Because starting thyroid hormone replacement increases the body's overall metabolic rate. If you rev up the metabolism without having enough cortisol on board to handle that increased demand and stress, you can precipitate an acute, life-threatening adrenal crisis. Cortisol must be replaced first, or at least simultaneously, before giving thyroid hormone in this specific scenario. Hashtag tag 1.3 adrenal crisis, acute adrenal insufficiency.
That's a perfect segue into adrenal crisis itself. This isn't the chronic state, this is the acute emergency.
Absolutely. Adrenal crisis is acute, profound, life-threatening cortisol deficiency. It's an uncompensated state of shock.
What usually triggers it?
It's typically set off by some kind of major acute stress, think severe infections, surgery, trauma, even sometimes intense emotional stress in someone who already has underlying adrenal insufficiency, whether it's primary or secondary.
Or very commonly in someone whose own adrenal axis is suppressed from taking chronic steroids, right?
Exactly. That's probably the most common scenario we see now. Someone on long-term prednisone for, say, asthma or rheumatoid arthritis gets pneumonia. Their body needs a surge of cortisol to cope with the stress, but their own adrenals are asleep, suppressed by the medication. If they don't get extra stress dose steroids, they can crash into crisis.
What's the defining feature of the crisis? How do you recognize it?
The absolute hallmark is refractory hypotension or shock. We're talking severe low blood pressure that just does not respond adequately to giving IV fluids alone.
Why not?
Because without sufficient cortisol, the blood vessels lose their sensitivity to vasoconstrictors like norepinephrine. You can pour in fluids, but the vascular tone isn't there to maintain pressure. The patient is usually profoundly weak, maybe confused or lethargic, often nauseous, vomiting, and frequently hypoglycemic because cortisol is needed for glucose regulation.
This sounds like a situation where you can't wait for diagnostic tests.
Absolutely not. Time is critical. You cannot delay treatment waiting for a cosintropin test result if you suspect adrenal crisis clinically. The management priority is immediate action.
Which is?
Immediate, high-dose IV hydrocortisone. Dexamethasone is an alternative if you want to do diagnostic testing later, as it doesn't interfere with the cortisol assay, but hydrocortisone provides both glucocorticoid and some mineralocorticoid effect, which is beneficial. This must be given alongside aggressive IV fluid resuscitation, usually with normal saline, often containing dextrose to correct the volume depletion and any hypoglycemia simultaneously.
The sources were really emphatic about this. If you have a patient in shock, especially post-op or someone with any history of significant steroid use, and they're not responding to fluids.
You must treat it as potential adrenal crisis until proven otherwise. Give the IV hydrocortisone immediately. It's the one intervention that can rapidly restore vascular tone and potentially save their life. The risk of giving a dose of steroids is tiny compared to the risk of missing an adrenal crisis.
And it's important to remember that suppression can last a while after stopping steroids.
Definitely. Depending on the dose and duration of steroid use, the HPA axis suppression can persist for weeks or even months after stopping. That patient is essentially living with temporary secondary adrenal insufficiency, making them incredibly vulnerable if a major stressor hits. They need that stress dosing if they get sick or need surgery.
Okay, we've thoroughly covered what happens when the adrenals fail. Now let's completely flip the coin. We're moving from hormonal starvation to hormonal excess, starting with the consequences of too much cortisol. Cushing syndrome. Hashtag 2.1 Cushing syndrome. Excess cortisol.
Right. Cushing syndrome is the clinical state resulting from chronic, prolonged exposure to excess cortisol, and it can come from any source. It's crucial to remember the most common cause clinically is actually exogenous people taking high doses of steroid medications, like prednisone, or even high-dose inhaled steroids.
But when it comes from inside the body, endogenous causes, what are we looking for?
Then we're usually looking at three main possibilities. First, an ACTH-producing tumor in the pituitary gland. That specific scenario is called Cushing disease. Second, a tumor within the adrenal gland itself that's just autonomously churning out cortisol, ignoring signals from the pituitary. Or third, rarer, is an ectopic source of ACTH, meaning a tumor somewhere else in the body, often certain types of lung cancer, that has started making ACTH.
And the effects of all this extra cortisol are widespread, aren't they? It messes with metabolism, physical structure, everything.
It's incredibly pervasive. Let's start with the metabolic effects. Cortisol is fundamentally catabolic. It breaks things down, and it's a hyperglycemic hormone. It ramps up glucose production in the liver, gluconeogenesis, which directly leads to hyperglycemia, often causing new-onset type 2 diabetes or worsening existing diabetes.
And the weight gain, the classic Cushingoid appearance.
That's due to cortisol shifting fat metabolism and causing fat redistribution. You get that characteristic central obesity weight gain mainly in the trunk, abdomen, along with the classic moon face or facial plethora, and that fat pad on the upper back, the buffalo hump. Interestingly, the arms and legs often remain relatively thin or can even appear wasted due to muscle breakdown.
Ah, the catabolic effects. That breakdown of protein seems to cause some really distinctive physical clues.
Absolutely. Cortisol actively works against protein synthesis. This chronic protein breakdown leads to two major clinical signs. First, significant proximal muscle weakness. Patients will complain they have trouble getting up from a chair without using their arms, difficulty climbing stairs, or even just lifting their arms to brush their hair.
Is it painful?
Usually not. That's a key point. It's typically a painless weakness. And importantly, muscle enzymes like CK, creatine kinase, and inflammatory markers like ESR are usually normal. This helps distinguish it from inflammatory muscle diseases.
Okay, so painless weakness in the shoulders and hips. What's the second major catabolic sign?
That's seen in the skin. Cortisol breaks down collagen and the protein matrix in the dermis. This makes the skin become remarkably thin and fragile. Patients develop easy bruising, sometimes from just minor bumps, and very characteristic are the wide purplish or violaceous striae stretch marks typically found on the abdomen, but also sometimes on the breasts, hips, and thighs.
How are these different from regular stretch marks?
They tend to be wider, often more than a centimeter across, and deeper red or purple, not the pale pink or silvery lines you might see from pregnancy or rapid weight gain. They reflect more significant dermal tearing due to the cortisol effect.
Now, you mentioned earlier that sometimes really high cortisol levels can start acting like aldosterone. Can you explain that mineralocorticoid mimicry?
Yes, this happens particularly in severe cases of Cushing's, especially when it's caused by ectopic ACTH production, where cortisol levels can be astronomically high. Normally, an enzyme in tissues like the kidney deactivates cortisol, preventing it from binding strongly to the mineralocorticoid receptor, which is aldosterone's main target.
But if cortisol levels are overwhelming,
Exactly. The enzyme gets saturated, it can't keep up. So the excess cortisol does bind to the mineralocorticoid receptor and starts acting just like aldosterone. This triggers significant sodium retention by the kidneys, and along with it, potassium and hydrogen ion wasting,
Yeah, leading to.
leading to a dangerous combination of hypertension, significant hypokalemia, low potassium, and metabolic alkalosis. So if you see someone with florid Cushingoid, features the central obesity, the muscle weakness, the stri, and they have severe hypokalemia, you should strongly suspect a very high cortisol state, potentially from an ectopic source like small cell lung cancer.
Okay, so if the clinical picture strongly suggests Cushing syndrome, how do we approach the diagnosis systematically?
It's a two-step process, fundamentally. Step one, confirm hypercortisolism. We need objective proof that the body is actually making too much cortisol and has lost its normal regulation. We can't just rely on a single morning cortisol level, as that's too variable and easily affected by stress.
So what tests do we use for screening?
The standard screening tests are designed to look past the normal daily rhythm. The most common is the overnight low-dose dexamethasone suppression test. You give a small dose of dexamethasone, a synthetic steroid, at night. Normally, this should suppress the body's own cortisol production by morning. If the morning cortisol is not suppressed, that's highly suggestive of Cushing's.
Other options.
Yes, measuring 24-hour urinary-free cortisol is another good one. High levels confirm excess cortisol excretion over a full day. Or you can measure late-night salivary cortisol. Cortisol levels should normally be very low late at night. Persistently elevated levels in saliva collected then also indicate Cushing's.
Okay, so let's say one of those screening tests is positive. We've confirmed hypercortisolism. What's step two?
Step two is determine the etiology. Where is the excess cortisol coming from? And the key test here is measuring the plasma ACTH level.
How does the ACTH level help us figure out the source?
It's the crucial branching point. If the ACTH level is low or suppressed, it means the problem is not being driven by the pituitary. Either the patient is taking exogenous steroids, which suppress pituitary ACTH, or there's an adrenal tumor autonomously producing cortisol, telling the pituitary to shut down ACTH production via negative feedback. This is ACTH-independent Cushing's.
And if the ACTH level is high?
If the ACTH level is high or inappropriately normal in the face of high cortisol, it means something is driving the adrenals via ACTH. This is ACTH-dependent Cushing's. The source is either the pituitary gland itself, Cushing disease, or that ectopic ACTH production from a non-pituitary tumor somewhere else.
So low ACTH points to the adrenals or outside steroids. High ACTH points to the pituitary or an ectopic source. How do you tell those last two apart, pituitary versus ectopic?
That often requires further testing. Most commonly, the high-dose dexamethasone suppression test. The principle is that pituitary tumors causing Cushing disease, while abnormal, often retain some degree of sensitivity to negative feedback. So, a very high dose of dexamethasone will usually suppress cortisol production partially.
Whereas an ectopic source?
An ectopic ACTH-producing tumor, like a lung cancer, is typically completely autonomous and rogue. It doesn't respond to feedback signals at all. So cortisol production will usually not suppress, even with high-dose dexamethasone. That lack of suppression strongly points towards an ectopic source. Imaging of the pituitary, MRI, and chest-abdomen, CT, is then used to locate the tumor.
And management ultimately comes down to finding and treating that underlying cause.
Exactly. If it's a pituitary or adrenal tumor, the primary treatment is usually surgical removal. If it's an ectopic source, you treat the underlying cancer, although that can be challenging. And if it's exogenous steroids, the approach is very careful. Gradual tapering of the steroid dose, allowing the patient's own suppressed HPA access time to wake up and recover function, which can take months. Hashtag 2.2 primary hyperaldosteronism, Conn syndrome.
Okay, we've covered excess cortisol. Now let's move to the other major adrenal steroid, excess aldosterone. This is primary hyperaldosteronism, often called Conn syndrome when it's caused by a specific type of tumor.
That's right. Here, the issue is autonomous, unregulated secretion of aldosterone by the adrenal glands. It's usually caused either by a solitary aldosterone-producing adenoma, a benign tumor, that's classic Conn syndrome, or by bilateral adrenal hyperplasia, where both glands are enlarged and overproducing aldosterone. Importantly, cortisol production is usually normal in this condition.
So this is primarily a disorder of salt and water balance, driven by too much aldosterone. What's the classic clinical picture?
It revolves around a core triad of features, all stemming directly from aldosterone's action on the kidneys.
Okay, number one.
Hypertension. Because aldosterone makes you retain sodium and water, expanding blood volume, these patients almost always have high blood pressure. And critically, it's often severe and notably resistant to standard multi-drug antihypertensive therapy. That resistance is a big clue.
Makes sense. Number 2.
Hypokalemia, low potassium. As the kidneys retain sodium under aldosterone's influence, they waste potassium into the urine. This chronic potassium depletion can lead to symptoms like generalized fatigue, muscle weakness, severe muscle cramps, and sometimes even dangerous cardiac arrhythmias.
And number 3. This one's key for diagnosis, right?
Absolutely key. It's suppressed plasma renin activity, PRA. Renin is the hormone released by the kidneys when they sense low blood flow or low sodium. Renin normally kickstarts the process that leads to aldosterone production. But in primary hyperaldosteronism, the body is volume expanded due to the excess aldosterone. The kidneys sense this high volume pressure and shut down renin release, so you have high aldosterone despite low renin. That mismatch is the hallmark.
Now, here's something interesting the sources mentioned. Despite all this chronic sodium and water retention, these patients usually don't get significant peripheral edema like swollen ankles. Why is that? It seems counterintuitive.
It does, doesn't it? This is the phenomenon known as aldosterone escape. While the initial effect of aldosterone is indeed sodium and water retention, as the body's volume starts to expand, counter-regulatory mechanisms kick in. Primarily, the heart muscle itself, when stretched by the increased volume, releases natriuretic peptides, hormones like AMP, atrial natriuretic peptide, and BNP, brain natriuretic peptide. These hormones act on the kidneys to increase sodium and water excretion, partially counteracting the aldosterone effect.
So the body finds a way to escape becoming massively fluid overloaded.
Exactly. It reaches a new steady state with hypertension and maybe mild fluid retention, but typically avoids the gross edema you might see in heart failure or nephrotic syndrome. That lack of significant edema, despite the hypertension and hypokalemia, is actually another subtle clinical clue pointing towards primary hyperaldosteronism.
Okay, so how do we definitively diagnose it? You mentioned the renin and aldosterone mismatch.
The cornerstone of diagnosis, certainly for screening, is the plasma aldosterone concentration, pH, to plasma renin activity, PRA ratio. We measure both hormones, often under specific conditions, like after sitting or standing for a period, and calculate the ratio.
What ratio are we looking for?
A high PAC combined with a very low suppressed PRA results in a high PAX PRA ratio. Generally, a ratio greater than 20 when aldosterone is an NGL and PRA is an NGM LHR, though units matter, is highly suggestive of primary hyperaldosteronism. It confirms that aldosterone production is inappropriately high for the level of renin stimulation, essentially. It's autonomous.
It's really important to distinguish this from secondary hyperaldosteronism, isn't it? Where both renin and aldosterone would be high.
Absolutely crucial. In secondary hyperaldosteronism, think conditions like renovascular hypertension, narrowing of the renal artery, or severe heart failure, or even just dehydration. The kidney perceives low perfusion or volume and appropriately releases high levels of renin. This high renin then drives the adrenals to make more aldosterone. So both renin and aldosterone are elevated, and the ratio might be normal or even low. In primary hyperaldosteronism, cons, the problem starts at the adrenal producing too much aldosterone, which then suppresses renin. That suppressed renin is the key.
And sometimes diuretics can confuse the picture.
They can. Diuretics, especially thiazides, cause volume depletion and potassium loss, which can stimulate renin and aldosterone, mimicking secondary hyperaldosteronism. That's why it's often ideal to stop potentially interfering medications for a period before testing the PAS-CPRA ratio, if clinically safe to do so. But even with diuretics, a profoundly suppressed PRA in the face of high aldosterone still strongly points to a primary cause. Oh, and these patients also often have a mild metabolic alkalosis, similar to severe Cushing's, because the aldosterone-driven sodium reabsorption is linked to hydrogen ion secretion in the kidneys as well.
So once the biochemistry confirms primary hyperaldosteronism, what's the next step for management?
The next step is usually adrenal imaging, typically with a CT scan, to determine if the cause is a unilateral adenoma, Conn syndrome, or bilateral adrenal hyperplasia. This distinction is critical because it dictates the treatment approach.
How so?
If imaging clearly identifies a solitary adenoma on one side, the treatment of choice is usually laparoscopic adrenalectomy, surgical removal of that adrenal gland. This is often curative, resolving the hypertension and hypokalemia.
And if it's both glands that are overactive? Bilateral hyperplasia.
But then surgery isn't the answer because removing both adrenals would cause Addison's disease. For bilateral hyperplasia, the treatment is medical therapy using mineralocorticoid receptor antagonists. These are drugs like spironolactone or eplerenone. They work by blocking the aldosterone receptor in the kidney, preventing the excess aldosterone from causing sodium retention and potassium wasting. Eplerenone is often preferred as it's more selective and has fewer anti-androgen side effects, like gynecomastia in men, than spironolactone. So we've journeyed through both the failures and the overproductions of the adrenal gland. If there's one really central theme that emerges from all the sources, it's that the body's electrolytes, particularly sodium and potassium, alongside the ACTH level, act like an incredibly precise roadmap. They guide you directly to the specific adrenal problem if you know how to read them.
Yes, synthesizing all that information really comes down to connecting those dots. ACTH, pigmentation status, and, crucially, the potassium level. Let's try to crystallize that differentiating grid for everyone listening. It feels like the absolute key takeaway.
Okay, let's do it. Think primary AI, Addison's. The problem is in the adrenal gland. It can't make cortisol or aldosterone. Low cortisol means the pituitary screams louder. High ACTH. High ACTH plus its precursor hyperpigmentation. No aldosterone function, hyperkalemia, high potassium, and hypotension. Needs dual hormone replacement.
Got it. High ECTH, pigmentation, high potassium. What about secondary AI? Secondary AI, SAI. Problem is in the pituitary or hypothalamus. It's not sending the ACTH signal, last low ACTH. Low ACTH means no hyperpigmentation. But aldosterone production is preserved because it relies on the renin system, not ACTH. Therefore, des normal potassium. Still get hypotension from low cortisol, needs only glucocorticoid replacement. Perfect. Low ACTH, no pigmentation, normal potassium. Now switching to the excess states. Cushing's syndrome, focusing on severe endogenous. The driver is high cortisol. ACTH can be high if it's pituitary Cushing's disease or ectopic ACTH, or low if it's an adrenal tumor making cortisol autonomously or exogenous steroids. Key metabolic signs. Hyperglycemia, hypertension. And importantly, if cortisol levels are very high, they could overwhelm the system and act like aldosterone, leading to hypokalemia, low potassium, and metabolic alkalosis, right? A variable ACTH, but potentially low potassium if severe. And finally, Conn syndrome. Conn syndrome, primary hyperaldosteronism. The problem is autonomous aldosterone production. Cortisol is usually normal. It has a volume expansion from aldosterone. Renin is suppressed. And typically pituitary ACTH might also be slightly suppressed. Low ACTH, low PRA. Key features. Hypertension and significant hypokalemia. The defining feature is that aldosterone is high despite the low PRA. That grid really lays out the core physiological fingerprints. And understanding those patterns reinforces why we use specific diagnostic tests for specific situations.
Exactly, they're not interchangeable. The cosintropin stimulation test directly probes the adrenal gland's ability to respond to ACTH, essential for diagnosing primary adrenal failure.
Whereas the dexamethasone suppression test checks the integrity of the negative feedback loop. Can the HPA axis be appropriately shut down? That's key for diagnosing Cushing's syndrome.
Precisely. And the passive PRA ratio specifically assesses the relationship between aldosterone and its main regulator, renin, to diagnose autonomous aldosterone production in Conn syndrome. Each test answers a different physiological question.
What strikes me, reflecting on the sources, is how relevant this is beyond just textbook endocrinology. So many of these conditions start with symptoms that are incredibly common, incredibly vague.
That's a critical point. Think about profound fatigue, generalized weakness, maybe some depression or anxiety, persistent nausea, unexplained weight loss or gain. These are things people experience all the time.
Right. And the sources highlighted how often patients with Addison's, for example, get diagnosed initially with depression or chronic fatigue syndrome, sometimes for years.
Until someone finally picks up on that subtle clue, like maybe they mention craving salt or a family member notices their skin looks a bit darker, especially in the creases.
Or recognizing that the painless proximal muscle weakness in Cushing's isn't just someone getting old, or that resistant hypertension combined with muscle cramps isn't just essential hypertension that needs another pill.
Exactly. It's about having that index of suspicion. It's about seeing these combinations: fatigue plus salt craving plus low BP, or weakness plus bruising plus central obesity, or resistant HTM plus low K plus, and thinking, wait, could this be an underlying endocrine disorder? Could this be the adrenals? That's the practical knowledge we hope you can take away and use. #MoeUTRO.
Well, we have certainly navigated the complex terrain of the adrenal glands today, from complete failure to dangerous excess. We've really tried to extract those key nuggets, those physiological fingerprints that help distinguish these often confusing conditions.
Yeah.
It really highlights the delicate balance the body maintains.
It Absolutely does. And it makes you think, doesn't it? We all tend to attribute things like fatigue or weight changes or mood swings to, just daily life stress, not enough sleep, maybe getting older.
Sure.
But when you consider the incredibly broad and sometimes seemingly unrelated symptoms that adrenal disorders can cause, everything from muscle wasting and fragile skin in Cushing's to that intense salt craving and skin darkening in Addison's, it really poses a final, quite profound question for you to consider.
Hmm.
How many of those common, vague symptoms that people experience every day are actually the body's own sophisticated alarm system, signaling a much deeper, specific hormonal imbalance? And how easily might these crucial signals be missed simply because they get mistaken for purely psychiatric issues or just generalized not feeling well instead of being recognized as a specific story the endocrine system is trying to tell?
That's a powerful thought to end on. Are we listening closely enough to what the body might be trying to tell us through these seemingly common complaints? Use these insights. Keep asking those questions. Thank you for joining us on this deep dive. We look forward to the next one.